Hi everyone. So good morning, good afternoon, good evening to anyone who's joining from any corner of the world. I'm Dr Manan Thakrar. I'm a consultant psychiatrist. I'm based in the UK. I did my training mainly in India, and then I did my Royal College of Psychiatry exams for the UK, and I'm now practicing here in the UK. Today I've got a really special guest, someone who I really do look up to. I've got Dr Gierynski with me. He's a consultant psychiatrist. I've worked in the same organization as him for 2.5 years. So by the time this video comes out, I don't know if we'll still be working in the same organization, but he's someone who has done immaculate, very impressive work, especially with borderline personality disorders. He's a wonderful human being, and I've always, like I say, looked up to him for advice, for guidance, for counsel when I came to this country. Dr. Gierynski, I'll let you introduce yourself, and then I'll start off with some questions.
Thank you for very kind introduction. You always, every time you talk to me and talk about me, you make me blush, because you're always so praising and so kind of nice. My name is Dr. Wojciech Greg. I am a consultant psychiatrist working, as you mentioned, for the same organization, Navigo, which is based in the UK, Northeast Lincolnshire, Grimsby. And I have been working for Navigo the last over 17 years. My career in psychiatry started a bit earlier than this, because I've been practicing psychiatry for 27 years now, believe me or not. It's quite a while. Initially, I was trained in Poland, where I was born, and then I moved to the UK in 2006, once completing my specialist training and once securing my consultant's post in Poland. So then I've been headhunted by Navigo and brought here, and this is where I've been for the last 17 years.
What got you interested in psychiatry to get us started?
That's a really interesting question, because I've been interested in psychiatry or psychology, like in broad terms, for as long as I can remember, from really a childhood. It sounds like a cliche, but that's really the case. So I chose to go to the medical school purely to end up in psychiatry. I don't get me wrong, but it may sound wrong, but I wasn't interested in medicine as such or as much. I was just interested in psychiatry, and it was the vehicle to get me to where I wanted. So that this is how it happened, and it was so natural for me. So I can't even answer why. It's just what always fascinated me: the human behaviors, human brain, how people, why people do whatever they do, and trying to understand and help them and understand myself on a way. Something that's been always fascinating me. How was it for you?
I think it was pretty much the same. My dad's a psychiatrist, and I've got a couple of different doctors in my family as well. So I've got an uncle who's a neurosurgeon, an uncle who's a pediatrician, mom's a dermat. I've had the unique opportunity to shadow all of them as well while going through medical school by myself. But psychiatry has always been the most fascinating one. And I've always told this to everyone that, artificial intelligence is probably going to take over. Artificial intelligence, and along with robotics, is going to take over a lot of branches of medicine, but I'm not sure whether it'll completely take over psychiatry because of that beauty of that, it's about stories.
It really is. It really is. And it's about theory of mind, in a sense of getting into a very in-depth of understanding of why people behave the way they do and what drives them to do it. And similarly to you, I would like to believe that humans are irreplaceable in that field, but who knows? Time will tell.
Yeah. With regards to training, Dr. Gierynski, so I'll just throw a little bit of light on how training works in India. After your MBBS or after your undergraduation, you do 3 years of training in psychiatry, which gives you a degree of MD psychiatry. There are a lot of DM courses coming up. You can do DM in geriatric, in child and adolescent, stuff like that in India as well now. Of course, training in the UK is more like 3 years of core training and then 3 years of higher training. And if you're an international medical graduate like myself, I did CSER, which was, instead of doing the 3 years of higher training, I did the Royal College of Psychiatry exams, and then I submitted my CSER portfolio. What is the training pathway as far as psychiatry is concerned in Poland, and do you have subspecialty? How does that work?
In Poland, it's basically very similar to the UK, so there's not that much different. When I was, and it was quite a while ago, but it hasn't changed as much. My medical school was 6 years, and then we had a postgraduate year of the foundation program. It's been extended to 2 years since, but when I was graduating 27 years ago, it was 1 year, and then specialist training, which was and is divided into the two parts. 3 years each. So the first degree, as it was called in Poland, equivalent to the core training, 3 years training in more generic psychiatry, and then a specialist part of it, another 3 years, which used to be called the second degree of psychiatry, which is more specialists in subspecialties like general adult psychiatry, child and adolescent psychiatry, old age psychiatry, very similar to what it is in the UK. So yeah, nothing really exciting to say different.
So it's pretty much like the 6-year training pathway that you've got here.
It is, yes.
Right. And I know that you've done, and we're going to dwell into that now, that you've done amazing work around borderline personality disorder. And I think that's what we might want to center the rest of the conversation around. Just for us to get started, how would you, for anyone who doesn't have a background in psychiatry or psychology, my side of the country where I come from, it's mainly, we usually follow DSM, and hence we call it borderline personality, whereas here in the UK, we use EUPD as the title a bit more. But just to throw some light on borderline personality disorder, how would you describe someone who has a diagnosis of borderline personality disorder?
I suppose because the audience, I suppose, will be quite wide with professionals and non-professionals, the best starting point would be to define what is personality disorder as such before going to the borderline personality disorder, or even a step before what is personality, because I suppose to understand, and that's how I always teach my students, before I go to personality disorder, you really need to understand what the concept of personality in psychology and psychiatry. And personality is basically about how we feel, think, and behave. And it is about patterns of your emotions, how you experience your emotions, how you display them, how you respond emotionally, and how you behave, how you think. Talking about patterns is the key thing, because when we talk about the personality, it is about talking about the repetitive patterns of behaviors, not something that we can observe in one point of time, but more longitudinal. We all, as you will know, and everyone listening to it will know, we all have personality, and we differ in the way we behave, we differ in the way we respond emotionally, and so on. That is why we've got the whole range of different personalities, but as long as they are functional, so help us function in the society, and they are socially acceptable, we talk about like a normal, healthy, acceptable personality, which takes us to the subject of personality disorder. Really, when we talk about crossing the line between a healthy personality and personality disorder, and this happens when someone displays again the patterns of behaviors that become dysfunctional, that deviate from the expectations of the society, of the culture, and as the result of this deviation create the problems for a person suffering from it and difficulties in their social functioning. So, and again, it is really important to repeat over and over again. I don't think it's ever enough to stress that we talk about enduring and inflexible patterns of behaviors that deviate from the expectation of society. We don't talk about the behaviors that dysfunctional or out of character, that are unexpected as a result of the crisis or as the result of the short-lived adjustment things going on in life, because people sometimes do behave out of character. People sometimes behave in a way that is not acceptable socially because of the level of stress they undergo, the pressures from different situations in life, the adjustment situation, and so on. But as long as those are short-lived behaviors, we are not talking about personality disorder. We talk about personality disorder only when those maladaptive behaviors, or the behaviors that deviate from the expectations, however you want to describe them, are long-lived and inflexible in their presentation. So that's generally personality disorder, and there's the whole range of different types of personality disorder. As you mentioned, my focus and our focus for the discussion today is borderline personality disorder, or emotionally unstable personality disorder, as it is described in ICD-10. And the reason for the focus and the reason for my special interest is because this is the most common presentation of personality disorder in mental health services. So most people, if most people who present with a personality disorder to mental health services, they usually present with this type. And another reason for my interest and for mental health focus on borderline personality disorder is that they create this type of disorder creates so much personal suffering, so much personal distress, and so much of the distress for the people living around individuals suffering from this condition.
It's really interesting that you say that. So just to summarize what you said, it's a particular pattern of thinking, feeling, and behaving that
Yeah.
describe someone's personality. We need to make sure that it is enduring and it is long term. Most personality patterns are developed by, say, adolescence or early adulthood. And you said that emotionally unstable or borderline personality disorder is something which is the most common personality disorder presentation in mental health services. How would you describe someone, or what symptoms would you describe for someone who has borderline personality disorder commonly? Like, if someone who doesn't have any background with psychology is watching this video, what are the warning signs or what are the trigger signs that you would see which would raise alarm in their head that, oh, this person that I know or this person that I love and care for might have borderline personality?
There are like core traits or core symptoms for the borderline personality disorder that we see in a different configuration in most patients. And one of them is poor self-image or difficulties in self-identity, self-image, which we might get to the point of discussing the roots of borderline personality disorder and how it is developed. So it's at that point it might make more sense of how it's developed and why it is. But the end result is that people with borderline personality disorder usually not very confident, in a sense that they've got self-esteem, they don't believe in themselves, or this self-belief or self-worth fluctuates or changes quite rapidly. So they might feel quite okay about themselves. They may have some plans and ideas about what they may want to achieve in life and be quite positive about it 1 minute, but then quite easily undermined by anything happening around them, people's opinions, people's judgments, how people talk to them, how they even look at them, and the next minute, from feeling quite good about themselves, they may crash down to feeling absolutely useless, stupid, and so on, and unable to achieve their life goals, which obviously is a very painful and very difficult feeling, resulting in some of the behaviors like self-harming, like attempts on suicidal attempts and then so on. So this self-view is one of the core elements of the personality disorder. Another core element is the emotionality, and the emotionality in borderline personality disorder is placed with the mood instability, with mood being quite changeable and changing again, similarly to like a self-image, changing from being quite positive, even sometimes elated 1 minute, and next minute crashing down and feeling desperate, low, useless, and so on. And it is quite important to understand and note here that this self-image and this mood instability is quite reactive to what's going on around the person. So the person usually has poor ability to self-regulate and self-adjust to what's going on around them. In a healthy person, we would, healthy in inverted commas, it's quite a difficult concept of what is healthy and what isn't socially, but I don't want to digress too much here. But generally saying, it's generalizing, I know it might be painful for some people to hear, but a healthy person without a disorder would be expected to self-regulate if other people judge them harshly, if other people say something critical about them, to self-regulate and self-reassure about their self-worth, not leading to the mood changing as rapidly as we observe in people with borderline personality disorder who do not usually have the skills of self-regulation. And as a result, and kind of going hand in hand with mood instability, is the impulsivity, which displays in the behavior. So they usually engage in impulsive behaviors and impulsive acts, impulsive decisions making without considering consequences of their behaviors. And a part of this impulsivity is the suicidality and risk-taking behaviors like self-harming, but this impulsivity shows in many other areas of life, not simply in risk-taking behaviors. There's a couple of other aspects that are affected in borderline personality disorder. A big area is the interpersonal area, so the area of relationships, for all sorts of reasons, again, quite complex and possibly a bit too complex to explain here, but people with borderline personality disorder end up finding it difficult to develop and maintain long-lasting, healthy relationships with other people. You might understand it when you think about what I said earlier about very sensitive self-image, and as a result of them feeling very easily judged, criticized by other people, they are very sensitive in interpersonal relationships, and that's why they fall out with people very easily. They find it difficult to maintain like friendships, but also maintain work, employment, and other social links, because how people see them or how they perceive that people see them is quite painful and challenging for them and leads to those fallouts very easily. It's also related to general schemas of thinking, which usually is described in borderline personality disorder as black and white thinking. So thinking in quite narrow and extreme terms of judging things as either good or bad, either black and white. And this is also, it also has a massive implication on interpersonal relationships, because when you imagine someone seeing their relationships, friendships, and other people in those terms as having to be either perfect, either good, either ideal, or if they cannot be, and no one can be always ideal, perfect, they are useless and hopeless and dead in the water. And as we sometimes hear from them, this type of expectations and seeing people in relationships does not warrant the stable and long-lasting contacts and relations with other people. The final element that we see quite a lot in people with borderline personality disorder is experiencing stress-related dissociation or stress-related paranoid ideations to the point of they may experience stress-related quasi-psychotic episodes. And that's again going back to the theory of mind. This is how the stressed brain works, when the frontal lobes and the parts of the brain, prefrontal cortex primarily, and the parts of the brain responsible for logical thinking, for interpreting the reality, for making sense and judging what's going on around, when those parts of brains are very fragile and sensitive to stress, and under the conditions of stress they may not be able to work so easily. And this is when people with borderline personality disorder, in people with borderline personality disorder, the limbic system that is overactive takes over, and this thinking is replaced by emotional decision making and impulsivity, and also when this logical thinking prefrontal cortex part of the brain doesn't work, the other elements like producing psychotic slips in here and takes over in the presentation.
It's really interesting, and thank you for that basic idea about borderline personality disorder. Just to say that it's mainly problems with self-image, problems with being able to regulate emotions, problems with impulsivity, problems in maintaining long-lasting relationships, and some sort of psychosis might creep in because of all these issues. Why do people end up having borderline personality disorders? What is the cause of it?
I don't think there is one answer to it. There's a lot of concepts about it. So I'll try to keep it quite safe today and start from answering in very general and vague terms. So in vague terms, there is a combination of nature and nurture generally. And the proportion of it obviously is impossible to establish very scientifically. But most scientists or psychologists, neurobiologists tend to think that there's about half of influence of the nature, which is like genetic predisposition, and nurture, which is like the environment impact, the way people are brought up, the influence of the environment throughout the forming years, the first few years of the people's life. So I'm not going to talk too much about the nature, because it's quite complex and we don't know exactly which genes and what combination of them. At this stage, we don't have the very detailed science around it, so I'm not even pretending I know all those details, because I don't think anyone does. The nurture is really interesting aspect of it, and we know for fact that not all people, but most people with the borderline personality disorder have some childhood adverse experiences, which is the experience of some form of abuse, whether it is psychological, physical, or sexual, or neglect. And whichever way which the experience go, the common ingredient in it is their emotional needs, and their emotional development is challenged at the very early stages of their life. So we're talking about in Marsha Linehan's DBT, biopsychosocial model of borderline personality disorder. Marsha calls it an invalidating environment that predisposes people to developing borderline personality disorder. And even though I'm not the biggest fan of the DBT, and we might get to this at one point as well, which doesn't mean I have anything against it, but yeah, we might get to this. I like the concept of invalidating environment and Marsha's model because it really describes it in a very clear and simple way. So what Marsha Linehan says is that when people are brought in the environment, when in the first years of their life, their emotional needs are not recognized and their emotional needs are not fully met, in a sense that when they show up some emotions, those behaviors are invalidated by the environment or ignored or punished. So people might be punished for crying, or children. They might be punished for expressing the dissatisfaction. They might be punished for expressing anger, upset, or whatever, because children should be seen by not heard, or the children shouldn't disturb adults, or whatever the belief in adults is about how children should behave. It might end up in their emotional needs not being validated. And it goes even further, and we touch the attachment theory here, which is really crucial to understand how people's emotions and emotional regulation develops. We need to go to the attachment concept. And in that concept, we tend to believe that people can learn about their own emotions, how they recognize them, how to label them, and how to regulate them only through the attachment relationship with an important person in their life, usually the primary carer, mother, father, or other primary carers, because that's how we learn about our emotions. So if you can imagine a very young baby when they cry, in like an ideal scenario when the attachment is healthily developing in a family, the mother or the carer, the person caring for the person, would pick up the baby and kind of reflect the distress on baby's face on the face of the carer by grinning, doing whatever mothers, fathers, and other people do. And in that way, children can see themselves in the face of the carer like in a mirror, and learn how my face look by looking at the face of my carer. But then usually the carer will go further and smile and reassure the baby and kind of soothe the baby. And then the baby learns that distress and any other form of distress can be regulated, can be soothed, and is short-lived. And that's how baby learns about the emotions and how to regulate them. And it's the same with other emotions, with happiness, with smiles, and through the playfulness with the carers and so on. So in a healthy attachment in the families with a healthy attachment, children learn about themselves, about the emotions, and learn how to call them, because carers would talk to them and say, "Oh, you're happy, you're sad, oh, what's going on? Why are you angry?" Would label those emotions, would do all those things that gives the opportunity for the child to learn about themselves. And as a result, by the time they reach adulthood, they would be able to self-regulate in a healthy way. However, if things go wrong in families, in a sense that for all sorts of reasons, and the last thing I would like here is to judge the parents or carers, because that's not my intention whatsoever. It's just to state the fact that sometimes carers or parents are unable to do these things for all sorts of reasons. They might have their own mental health issues. They might be too caught up with their interpersonal, relational difficulties, the challenges of the the modern world and everything else. For all sorts of reasons, sometimes children don't have those ideal circumstances created when they are in a very early stages in life, and as a result they don't have an opportunity to learn about their emotions, to label them. Saying for all sorts of reasons, sometimes children don't have the opportunity to learn about their emotions, to label them and to regulate them, and as a result they end up with the emotions being all over the place, and then being unable to regulate them, with them being impulsive, with them being unable to control their behaviors and their emotionality, and in interpersonal situations that is emotionally very challenging always, because relationships are quite demanding emotionally for everyone. So you need good skills to be able to manage them, and if you don't have those skills implanted in you during the childhood, then you go into the adult life struggling with all those areas, and as a result you might end up with the presentation that meets the criteria for borderline personality disorder.
Thank you for that. Just to sort of summarize what you said, but it's nature and nurture. Appreciate the fact that there is limitations. One of the things that got us interested in mental health of the brain is that we know very little about, and it's fascinating. But that's also a limitation, that we don't understand borderline personality disorder or any mental health disorder for a fact, I think, as well as, say, we understand type 1 diabetes, or as clearly as we understand the pathogenesis of hypertension. And hence that is a challenge. As far as the nurture side of things is concerned, you mentioned a couple of really important and interesting points, I think. A, invalidating environment. B, emotional needs not recognized. When a child is punished for crying, not being able to express their distress and their problems in a healthy way. You touched upon attachment patterns, and I think that's a very fascinating concept. Loads of books, loads of attachment theories, and attachment patterns in itself helps us understand so much about anyone in general, more so I think for borderline personality. And when people learn to tolerate distress and regulate that distress, or regulate happiness as a child with their carer or with the person who's the closest to them, that is the founding stone or the basic pillar based on which then as an adult you start learning how to regulate your emotions. And that's probably the areas where the pathogenesis of borderline personality lies as far as the nurture side of things is concerned. If, say, someone has this diagnosis and has one of the most common presentations that people with borderline personality disorder eventually end up presenting to services or presenting to their doctor. In India, you end up directly going to the doctor or directly going to the psychiatrist. A lot of common symptoms is people who tend to cut themselves, people who tend to take frequent overdoses, people who tend to try to, on the surface of it, end their lives, but they are having a help-seeking behavior. And I do see a lot of stigma in not only the lay people, but also healthcare professionals for people who take overdoses or people who cut themselves, saying that, they don't even acknowledge the distress that people with borderline personality disorder go through when they're cutting themselves, because they just feel like, oh, he or she is just pretending to want to kill themselves. Mm-hmm. They actually want to kill themselves, and hence they don't get any empathy at all. Rather, a lot of times we see a lot of countertransference or a lot of anger towards people who suffer from borderline personality disorder. So I'd love for you to clarify on the difference between DSH or deliberate self-harm and active suicidal attempts, and where does the habit of wanting to cut yourself come from, and is it something that should actually evoke empathy in us as carers or in us as healthcare professionals, or should we stigmatize it because it's just attention-seeking behavior? I've actually seen it on patient records in the UK and in India, that the patient is exhibiting, in double inverted commas, attention-seeking behavior, or patient has become rowdy.
The last element of your question is the easiest to read. Should we show them empathy or should we judge them? That's pretty much not a brainer, isn't it? Obviously we are expected and we need to show empathy to any of our patients. It's a big part of our role, whether we are psychologists, psychiatrists, or working in any other parts of medicine. Compassion and empathy should underline everything we do. So that I don't think I need to talk too much about this. But yeah, I agree, it is challenging, and I believe that all those judgmental terms used towards people with borderline personality disorder come from the prejudice and the lack of understanding, basically, of the condition, because they sometimes, and especially in specialties when doctors and other professionals are really stressed and busy, you know, in environments like A&D or primary care, when professionals are really challenged with the challenges of the job, they might lose their empathy. I believe they always have it, but they might sometimes just lose it as a result of stress. People with borderline personality disorder, yes, they are sometimes described as attention-seeking. They are described as manipulating, and all sorts of terms are used. And I don't think it is the case that they are manipulating. So let's start from that term, which is quite common and quite hurting when it is being used. Every time it is being used, manipulation. I suppose we need to start from realizing or look into the dictionary what manipulation is. And if you look into the definition, it is a skilled behavior to influence other people to get what you want to achieve. So in a sense, if you look into the term, we are all manipulators in life. It is the skill that is necessary for life to living with other people. Otherwise, you wouldn't be able to influence other people. And I suppose being a good manipulator is the skill that is desired in the society to some extent. That the problem with borderline personality disorder is that they are not skilled to manipulate in a way that would be socially acceptable, and they do it in a more unskilled, almost like childish way as a result of lacking the skills. That is quite irritating people who would expect them to behave in more mature and adult way. And it is clearly the result of them never being taught by the curse. And again, we go back to the attachment theory throughout life to behave interpersonally in a more skillful way, and to talk about their distress in a more skillful way, and to be able to express themselves, their suffering, their problems in a way that would be socially acceptable. Because I think doctors or professionals expecting everyone to come and describe the in-depth of their emotional suffering from someone who is really stressed, who has been really hurt by life and by their experience, is absolutely, and most of our patients, especially when they present in crisis, would not be able to sit in front of you and tell you the life story and take you to all the roots of their behaviors for you to understand why they behave they do. Just not possible because of their upbringing and because of where under the stress. The only way they have to express their distress is to act it out through the behaviors like self-harming, like suicidal threats and gestures, because it's almost like the message. And I tend to see it as a message, you know, when people do those things, that they tell me, doctor, I want to help, can you listen to me? And that's what it usually is. And when you listen to them, when you sit down and spend some time with them and give them the chance to settle down first so that they can express themselves a bit more later, because it wouldn't be possible straight away when the prefrontal cortex are almost like cut off and are inactive. But when they settle down emotionally, when the limbic system settles down, and the other parts of the brain may regain its capacity. So as I'm saying, I believe that those behaviors are just the expression of their distress, and even more than this, the only expression, the only language they have to communicate their distress. This is a big part of every therapy for borderline personality disorder. Those individuals to kind of recognize that the meaning of those behaviors, recognize how it works for them, recognize those patterns, and learn more adaptive ways of communicating their distress. But it takes quite a while and a lot of therapeutic efforts, and that's not what's possible to achieve in like a short interaction with the patient and the crisis situation.
I'll use that as an opportunity to management side of things. And to start off, I'd like to tell all the viewers that Dr. Gierynski does a lot of work with the Sequoia therapeutic community, and he has chosen this niche. So I would love to learn more about what are the different therapies that you explored through your career for borderline personality disorders, and why is it that you chose this one? And to start off, tell us a bit about the awards and the recognition that you've received, so that people sort of just learn that, okay, so this is out there, this is actually functional, this is out there today, as of today, that There are therapeutic communities there. And then we can dwell a bit more deep into how it works and as well.
Yeah, so when I developed my interest in borderline personality disorder as a special interest, and it coincided with me coming to this country, because it gave me an opportunity to develop the special interest. This is how Navigo used to work and still work, giving the consultants kind of the opportunity to develop specialist services, develop special interest alongside the generic psychiatric work we all do. When I started looking into this area in more details about 17, 18 years ago, the primary model for the treatment of borderline personality disorder was dialectical behavior therapy, DBT, that's been developed by Marshall Linehan in America in 1990s of the last century, and then brought to this country soon after. So the beginning of this century, it started to develop and take shape, and there was a big guideline released, big paper released in 2003 called Personality Disorder, No Longer Diagnosis of Exclusion. Quite a lengthy title, but a massive, beautiful paper that we have been celebrating the 20th anniversary of this year. And this paper outlined how the services for people with borderline personality disorder should look like. Okay? So it gave us all the direction, because before that there were no specialist services, or there were very single isolated services that trialed different approaches, and they were kind of almost like experimental attempts to do things in a more effective and less excluding way. Well, as I say, when I started in 2006, shortly after releasing this paper, the DBT was believed to be the primary model. And I gathered the group of people within Navigo who were equally interested in doing something more progressive for borderline personality disorder, rather than just excluding them and sending them home saying that, we don't have any treatment for you, because this is how it looked like at the beginning of this century. And we identified DBT as the primary model, and we all trained in DBT. So I was trained, I underwent the national intensive training and the whole training in the DBT between 2006 2008, and then I developed the first treatment in this area, the first service called Personality Disorder Partnership, which was the full functional DBT service, with delivering the skills training and individual therapy and a consult and everything else meeting the criteria for the therapy. So this is what we were doing for roughly about 5-6 years initially, with a really good results. But over the time of doing it, I started also working as an inpatient consultant on one of the wards here, and I realized, and then I paired with Susan Brown, which you know as well, who is equally passionate about borderline personality disorder, and she was a part of Personality Disorder Partnership with me, and since then we've been doing different services together. And she was the manager for the ward. So around that time, we realized that even though doing some community treatment like DBT part-time service was not good enough for a couple of reasons. One of the reasons is that it was quite time limited, so it didn't offer or like capacity limited. It couldn't help a lot of people, and it couldn't help people with more complex needs who were in and out of inpatient wards, who were unable to come to the groups and sit in a group for 1.5 hours of 2.5 hours of skills training and take in quite complex theory and learn it and apply it in their lives, because their lives were so chaotic and so difficult that they just basically weren't able to apply whatever they've been taught in a skills training. Even when it was reinforced through the one-to-one. And we also noticed that there was a big gap of people being discharged from a ward and then having to wait months and months for any therapy available, and having no support, nothing to kind of give them a day-to-day opportunity to recognized, to be supported, to have people involved who would understand their problems and who would be able to give them the care they required. So we were exploring all sorts of different services. At that stage, we went on a tour around the country to see how other people worked, and we ended up in a couple of therapeutic services, therapeutic community services. And this is when the concept of therapeutic community really kind of gave us the light bulb moment. We realized that this is a kind of service, kind of therapy that might the needs of the individuals we were working with in much broader sense and much more holistically. The whole concept of therapeutic communities is fascinating, and I am a big fan of it. I mean, the therapeutic communities is something that has been in place in mental health since late 40s of the last century. It was first applied to the war veterans coming back from the Second World War with a lot of what we would now call PTSD. It was not called like this at that time, but they were presenting with all those symptoms and could not re-assimilate to the society because of the trauma they experienced and because of their mindsets and their emotions being so different to what normal average people were in life, that they just could not adjust to the normal life. And when they were put together to what then was called the therapeutic community in places with like-minded people with similar experiences, when they could just spend time with them, and they were like residential communities when they lived together for several months or years at a time, just living together, being listened by people who understood them, being understood by the professionals supporting them, and finding the way of dealing with the trauma and difficult emotions through talking about it to people who could relate to what they were saying and what they experienced. It proved highly therapeutic for them, and after this experience, they were able to come back to reality, to the society, and kind of live a quite functional life. So this concept was then applied to other conditions, including borderline personality disorder. In this country, most of the therapeutic communities nowadays are for that condition, are designed for that particular condition. The community generally are structured psychological environments that are very carefully designed, purposely designed to support people with specific conditions, offering them the opportunity for the group or for the environment being a treatment. The main therapeutic vehicle is the group of people living together. Or in our case, when we've got like a day community, it's not a residential community, and people not necessarily living together, but spending a quite substantial amount of time every day together. So how it works in practical terms, in terms of the Sequoia therapeutic community, our program is quite an extensive program lasting for 2 years in a main therapy program, followed by the 2 years of the maintenance program. So altogether 4 years of therapy contact. And for the main 2 years, people attend 3 days a week, 5 hours a day. So altogether 15 hours a week for 24 months. So if you do the calculation, it's a massive amount of time people spend within a democratic group of people, because the democracy and other values governing the therapeutic communities are essential, because it gives people living together, spending time together, a sense of ownership of whatever happens in therapy, and a sense of belonging, and a sense of having a sense of choice, a decision of what's going on with their life, something that they usually have been deprived throughout their life. And this therapeutic experience is almost like a corrective experience that gives them the opportunity to the past traumas, reevaluate some of the invalidation they experience from the society, but also learn a lot of social and intrapersonal skills they never had a chance to learn in a childhood, as I was describing earlier. So a big part of our therapeutic community program is not just sitting together and socializing for 15 hours a day. That's not the case. Although socializing and spending time together and doing things together like cooking, looking after the environment, having trips together, going to nice places, this is all important, and we all do it because it gives people, the members of our community, a lot of opportunities to learn the social skills they don't have another way of learning, but they also undergo specific therapeutic interventions. So in our case, it's MBT, so mentalization based treatment, implemented by dialectical behavior therapy skills. So during those 15 hours every week, they have some educational sessions when we kind of teach them those skills, help them understand the theory of mind and mentalization, the concept introduced by Fonagan Bateman, which you're aware of. And then we've got over the week 3 types of different psychoanalytic groups when they sit and they can explore their personal difficulties, including their traumas, in a way, in the environment that is safe and secure for them to do it. Otherwise, those are usually, they bring such in-depth traumas and difficulties, they wouldn't be able to look into them or process them with the people or in the environment that wouldn't feel safe and secure enough for them to do it. It obviously takes quite a lot of time for people who join the community to get to the point when they feel safe and secure to do it, but most of them reach this point after a few months when they can go deeper and explore it and reevaluate a lot of those things and end up learning different ways of behaving, different ways of managing their emotions. They change their thinking, they kind of shift away from this black and white thinking and brings more colors and more shades to their thinking. And as a result, I can proudly say that a lot of our graduates, a lot of people who complete our programs really turn their lives around, and we've seen a lot of remarkable examples of that over the last over 8 years since we first started as a quiet therapeutic community here in Grimsby.
It's really interesting that you mentioned the whole theory of mind side of things as well. While I give you a chance to take a couple of sips of your drink, I'll just quickly summarize a couple of things which were really interesting to me that you said. Is one of the things was that it is a total 4-year process. First 2 years is to start off, learn those skills, and 2 years for maintenance. It's 15 hours a week, 5 hours a day, 3 days a week. And it's a democratic group. I've had the privilege to attend a therapeutic community a couple of times, and everyone calls each other by their first name basis. Everyone sits together, cooks together. There is no hierarchy as such, which is really interesting. And I would love for you to throw some light mainly on, because a lot of psychology or psychiatry students would know about the theory of mind, and I don't want that to be repeated to them. But at the same time, theory of mind is something that we learn more in cases of autism, from a perspective of autism rather than borderline personality. So I would request you to walk us through a case from these 8 years, or from whatever. I completely understand the GDPR side, to talk and explain to us what mentalization based therapy is, what some basic concepts of it are. But rather than going into the theory, that if you walk us through a case for someone who presented to the therapeutic community, or you started working with them with these symptoms, and tell us a story as to how you then used the concepts of MBT, what they are living now, for us to paint a picture or learn a story about the pre and post side of things.
It's a massive request. I'm very grateful for it. I don't know how will I be able to do it. Like, summarize someone's 2 years journey in therapy in a few minutes time, but I will try. I don't shy away from challenges usually, but I can't resist to say something about mentalization anyway, so I will start from this. I don't want to go in depth into the theory, but the mentalization is like a different way of looking into the theory of mind, and mentalization is a massively helpful process, massively helpful concept rather. Basically, to make it the simplest possible, the concept of mentalization or mentalizing is the ability to understanding the mental states of yourself and others. And when we talk about mental states here, it's about how we feel, think, and behave. So exactly the same areas as we defined that define the personality as such. And that is one of the reasons why it is so effective in working with borderline personality disorder. Because again, if we go back to the point of our conversation when I was describing the borderline personality disorder core traits, in those individuals, their ability to flexibly understand what's going on for them and for other people is very much inhibited through the black and white thinking and through the lack of the skills in the process of upbringing. So when we in therapy give them the opportunity to reflect and gradually learn the skill of understanding and reflecting of what might be going on for them. So for example, when they come in the morning and say that I had a row with my partner and we fell out. So rather than judging the partner, say, oh, he's thick, sorry for swearing, you may cut it out if you wish later. And, and I don't want to have anything to do with them. Our relationship is over. So what we do in therapy, we just say, okay, that's fine. Let's sit down and think about what might be going on for you and for him in that situation. When you got angry after he didn't cook the dinner the way you wanted it to be cooked, what was going on for you? What was the judgment and meaning you gave in your head to his behavior? Did you think that he doesn't love you because he didn't do it the way you wanted? Or did you think he did that or the other? Let's think about it. Let's kind of broaden the range of possible explanation of the situation rather than saying in a very narrow way, I know that he did it because this, that, or the other. Because the normal response of the person with borderline personality disorder would be very black and white. They would be saying, I know exactly what it is. I know what people do. I know what people think. And this I know thing, what is called the psychic equivalence in mentalization, so just kind of knowing exactly everything, having answer to everything in your own head, narrows the world massively and kind of makes the relations with other people almost impossible. When you start to learn to be more open-minded about what other people do and why they might be doing whatever they are doing, and the same about yourself. Why am I feeling the way I'm feeling? What's going on for me? Is it this? Is it there or the other? Or is it a mixture of it? Accepting the complexity of the mind and all of those things really broadens up the perspective of the people and helps them accept whatever is thrown at them in life in a more skillful way. And it's a very general, very simplistic concept of mentalization, but this is what simply mentalization is. So we spend hours and hours over every week trying to make sense of what's going on for people's life and trying to make sense of their behavior, their emotions, and what's going on through their thinking processes. That's the mentalization element, and it is massively effective. I will very briefly give you an example of one quite an extreme presentation of the person who came to us at the quite early stages of our therapeutic community. And she wasn't a very young person when she came to us. She was in her 40s at that time. But her life for over 40 years of her life before she came to us was absolutely difficult and absolutely unbelievable for most of people. I suppose that would be the best word. So she was one of 10 children, like in the middle of the mix. And she was born shortly after her older brother, was born and died shortly after the birth. So when her mother got pregnant again, she got this concept in her head that the next baby will be the replacement for the lost boy. Okay? Which people sometimes have those ideas in their head. And when this person was born, and she was born a girl, her mother completely rejected her. She didn't want to even recognize she was born. So for the first 14 years of her life, her mother never spoke to her. She never spoke a single word to her. She communicated with her if she had to through her daughters, just telling her to do this, that, or the other, but wouldn't acknowledge her existence. So we can imagine what psychological damage it must have made on her. And as a result, she grew up as a very low confident, very timid, very shy girl who didn't speak much. And because she was very shy, very timid, and very insecure, when she went to school at the age of 5, she responded to it by just crying, and she couldn't stop crying. And because it was over 40 years ago, so hopefully the situation has changed and it wouldn't happen now. But the teacher reacted by slamming her at the back of her legs and saying, "There's no crying here. You are not going to cry here. Be quiet, because I'm not going to tolerate this behavior." So that person became quiet, and she refused to speak, and she never spoke at school. She was mute at school. There was something that we now would call selective mutism, but that's how she behaved at school, because this is what she was told, and she took it very literally, with the black and white thinking and lack of other skills. And I don't want to trigger any of the audience. Hopefully I will not, but the reality is that because she was mute, because she was very shy and very timid, she became a perfect subject for the abuse, and she was sexually abused by some other teacher later on at school, because she wouldn't tell anyone. She would be quiet, she wouldn't do anything about it, and she didn't. So this abuse lasted for some time, and she didn't do anything because she didn't feel like she could. She couldn't speak to her mother because mother didn't speak to her, and so on. And she ended up reaching the adulthood massively damaged, emotional and psychologically, not trusting people, not trusting anyone, not trusting that anyone can be safe for her. And so she was very isolated, not being unable to work, and so on and so on. She never went into any relationship as a result as well, as a result of this lack of trust and all the experience she has had. And then she went for another several years of life in and out of services with self-harming behaviors and difficulties expressing herself. So she was not very well understood by the services, like in 70s, 80s, which were like the services that didn't really manage those patients very well. And then later on in the 90s, she ended up adopting a boy from a family member and having a child. And she was a really good mother in a sense that she really looked after the boy very well, and she was very like making sure all his needs are met. But at the same time, she was kind of implanting in him all her insecurities and really panicking about him, to the point that when he was going to school, she was following him and standing outside of the school, making sure that he's safe there and he's not hurt in a similar way that she was. Which created a lot of difficulties for her with those behaviors. And later on in life, when he was a bit older, she was distressed, and she was afraid that he might leave her because he was growing up and he might find a girl and he might leave her. She got to the point that when she tried to kill herself and kill him, she was fortunately unsuccessful, but she ended up being sectioned for years in a hospital. So the story is extremely painful and extremely difficult. And when she was in our hospital several years ago, when I first met her, she wouldn't speak to anyone again. So the psychiatrists, psychologists, and other people that would want to help her understand her didn't have a chance to understand her, because she wouldn't really open her mouth to anyone and explain herself. So at the time when we set up this service, this acquired therapeutic community, we offered her a place in it. She initially wasn't very keen to do it because it is the group, but eventually she knew me from the world, and she knew Suzanne very well. And Suzanne was one of the few people whom she trusted, because Suzanne helped her with quite difficult things that were happening for her, and she never failed her, one of the few people who never failed her. So eventually she agreed to give it a go as an alternative of extended admission. And she came, and after a couple of years spent with us, the change would be unbelievable, to the point. I will give you a few examples, to the point that, and it was about the time when she was leaving, she was graduating. She wrote a beautiful story, a poem about her life, describing herself in such a beautiful way that when she presented it, and she presented it at the Royal College of Psychiatrists to a big audience when we took her to one of the conferences, there was no dry eye in the audience. People were so touched by listening to this testimonial and her story. talking in her own words about herself. But that's a kind of the glamour of it. But in the reality, in the meantime, her son got married and she allowed it. Initially, she absolutely loathed her daughter-in-law. She didn't want to speak to her because obviously she was stealing her baby from her. So she didn't want to talk to her. She didn't want to acknowledge her. She didn't do anything with her. And at the end of the therapy, she managed to persuade that girl to talk to her, because the girl was very highly offended by all of it, and she didn't want to speak to. But the mother-in-law, obviously, who would behave in that way, that's quite understandable. So she had to use all the skills to go there, explain herself, and convince the girl to give her a chance. And over time, she convinced the girl to allow her to see her grandchildren that were born in the meantime and spend some time with her, convincing her that she's not any danger to the grandchildren. And we're still in contact with her 8 years later. We see her occasionally, and she has 3 beautiful granddaughters, and she's regularly seeing them. They stay sleep over at her home, and she is enjoying the family life that she never had. And those kind of people are the individuals that make our effort worth. Or we've got a lot of more obvious successes, people who ended up in the employment, went to the university. We had a couple of babies in ATC over the 80 years because some of our members got married and got pregnant and had babies. So we see those children occasionally. Those are the Sequoia children now. So it's a very beautiful environment to work for. But the most important aspect of it is that it is really effective because of the in-depth of the work and the patience we offer them. It really, really takes time to open up to the strangers, to a group of people who they initially don't know at all, to trust them with their lives and with their difficult stories.
That was beautiful. Thank you so much for that. And I think that's why we're in this field. Mental health is such a passionate field to work in because results do take time. There are relapses. Like you said, it's been 8 years of you working with the therapeutic community and with the service user that you're describing as well. I'm sure that there were a lot of roadblocks, and a lot of times people do tend to one of the analogies that I use, and we were discussing this yesterday, that people are, even we as healthcare professionals sometimes, and even carers or even patients themselves, a lot of times feel really let down by themselves, or if you're a carer or a healthcare professional, you feel let down by the patient when they end up having a relapse. Someone with personality disorder, they end up having a relapse after 6 months, 1 year, 1.5 years, 2 years of being completely all right, no contact with services. Similarly, someone who has had an addiction problem in the past ends up having 2 wonderful years of being completely sober, and then something happening. And the analogy, I suppose, which is very interesting to use, is that if someone who had the diabetes under control for a couple of years ends up having a relapse of worsening of their diabetes, or someone who had been doing wonderfully well with regards to their physical health ends up having another, say someone who had a heart attack, taking really good care of themselves, watching their diet, exercising really frequently, but ends up having a relapse, ends up having another heart attack. You can't blame the person for that. You can't blame the person for their blood glucose levels going up suddenly. Yes, the diet might have contributed to it. Yes, there might have been some contribution, but we're all human at the end of the day. And in that process, being able to achieve this beautiful recovery, there will be roadblocks along the way. And we need to be really, I think, looking at it from a point of view of it still being a disorder and relapses being a part of the disorder, rather than looking at mental health that, I've had one episode of depression and I'm completely cured of it. No, because of the nature side of things that we discussed early on, our genes, our upbringing has made us vulnerable to the mental health complexities or the disorders that we end up having. And hence, just because we've gone through one episode really beautifully and come out of it, doesn't mean that we're completely, stealth and immunized to never ever having an episode of depression again.
Yeah, that's an interesting thing, and thank you for saying it, because I will challenge it. Because I think personality disorder, borderline personality disorder can be similar, but can also have a different outcome. And what I have observed over several years of working with the individuals with borderline personality disorder, especially 8 years of running psychotherapeutic community, once someone really engages in a therapy and completes the whole program, the whole 4 years, and engages in a sense that they really put an effort in learning the skills and applying them and changing their life around, we don't see relapses. Honestly, we haven't seen major relapses in this group of people. But I'm not saying it's everyone on the input finishing kind of fixed on the output. That's not the case. Absolutely, it wouldn't be true. But with those people who do engage and do the therapeutic work, the change is quite in depth, and the skills they learn are enough to manage life stresses and life crises to the point they don't end up on a ward, they don't end up with the services. Because we all experience stress. We all experience difficult life situations, but most of us do not end up in a hospital at A&D or with crisis team, because we manage with it using our skills. And it, finishing the therapy, most of our community members reach the point when their resilience is so high they can really manage a lot, generally as anyone else. So in a sense, if you diagnose them again, going through all the diagnostic tools, and the end of the process, they wouldn't meet the criteria for the diagnosis any longer. But it's the kind of the elite of the psychotherapeutic community, because there is a group of people always, and it's in the nature of the disorder and nature of humanity, I suppose. Some people do not, or are unable or unwilling to engage in that meaningful way, and they come to see what it is, to see how it goes, but they wouldn't make an effort. They wouldn't throw themselves wholly in it, and they wouldn't take a risk of exploring the difficulties in that environment, and they may drop out after a few months, sometimes later. Sometimes they may even finish but not engaging, and we wouldn't see that progress. So we've learned, the whole therapy team I'm working with, we've learned over years to kind of see the big difference and see who will have good outcomes by the way they approach the therapy, by the way they engage. And we are quite clear with people who are unable or unwilling to engage in quite early stages, to challenge them and encourage them to rethink their placement with us. If it's not the right time for them, if they are unable to engage, we might encourage them to leave and come back when they are ready. And we've seen quite a few people coming back after 2-3 years and really throwing themselves into it. And it's much better and much fairer to do it that way, rather than submitting someone for a difficult process and then kind of failing them in general terms if they are unable to do it, if it's not the right time to do it. So that's what I'm trying to say. That's a part of the experience, and we have gained over years to recognize that we are not omnipotent, and we are not there to help and rescue and fix everyone. We only can do whatever we can do and help those people who want to be helped and who are ready for it.
I think that's really interesting, because like you said, during those sessions you're doing chain analysis or psychoanalysis of traumas that one has been through their childhood. And of course, it's going to ruffle up a lot of traumatic memories. And even though you would have healthcare professionals with you who would be with you through that trauma, it is really triggering to go through that trauma again. And it needs to be the right time. In your life, it needs to be the right time to be able to go through that process. But it's beautiful to hear the stories of change. It's beautiful to hear this specific story where, someone who had been in a position where they had themselves gone through a lot of trauma, and then probably knowingly, unknowingly become a source of trauma for other people, then coming out and becoming beautifully rehabilitated into the society and functioning so beautifully. It inspires, I think, a lot of people to take up help and say that, there is light at the end of the tunnel.
Absolutely. I would definitely hope so.
And even as healthcare professionals, I think we derive a lot of passion and a lot of encouragement from the fact that a story like that would make me want to go back up and go to work a bit more sincerely, because it's stories like these which make us want to go to work and inspire us to give our best every day. Because mental health is a field where you're not doing a 2-hour surgery and the patient's cured at the end of the surgery. It is a long process, and it sometimes becomes a bit frustrating, I think, even as a healthcare professional or as a carer, to sort of keep that patience and wait for the results to come in, especially in light of the relapses that or roadblocks that might sometimes happen. But it's stories like these which give you a lot of encouragement and inspire you to keep giving.
And you're absolutely right. And I think this is why I'm personally such an advocate of the very robust therapeutic approaches like therapeutic communities, MBT, DBT, depending on the group of people, because it is important for the professionals to have effective tools at hands. The most frustration at professionals come from not having those tools available for them, not having those therapies available for them. When you face highly distressed people and there's not much you can do, it creates this sense of burnout. It creates this sense of therapeutic hopelessness and all of this that a lot of doctors, a lot of professionals experience. So it's really, really important to kind of upskill people working in those areas, to give them the tools to effectively work with this group of people.
Thank you so much for your time today, Dr. Gierynski. I think
It's my pleasure.
this
Thank
has been
you.
a fascinating conversation, and I'm sure all the people who listen to it, whether it be people who don't have any background with mental health or people who are psychology and psychiatry students, they'll end up taking away a lot from this conversation. I really look forward to having you again and going into further depth about a particular topic based on whatever the viewers want us to talk about. But like I say, thank you so much. It's always fascinating to talk to you. And thank you for being generous with your time and knowledge.
That's my pleasure. It is a pleasure to talk about it, and it's a pleasure to hear how things might work in other places. I didn't give you a lot of the chance to talk about this. Maybe next time I will be more mindful and ask you and be able to about your own experience. That would be really fascinating. So apologies for taking over but as you can see, I'm so passionate about it that when I start talking, it's very difficult to stop and limit myself, because that kind of the passion takes over.
As a student of psychiatry, and this was a fascinating conversation for me. I got to learn so much, and especially because I think a lot of the challenges that you talked about, I think the more I've worked across India and the UK, I discover that irrespective of culture, irrespective of upbringing, the challenges are pretty much the same. Over from India to the UK, I used to think that the stigma here would be much less, but mental health is still stigmatized. There's a lot of work that needs to be done. Transference and counter-transference across people who work in the healthcare field also is a massive challenge. And hence it's across cultures, across upbringings, across different types of populations. I think the challenges still remain the same, and hence the opportunities do as well. So it's been fascinating. I've been making notes because I've enjoyed learning, and it shows how passionate you are. So thank you so much for that. And like I said, looking forward to having a further discussion again.
Lovely. Thank you very much for your time, and hopefully see you again soon.
Thank you. Thank you.
Take care. Have a good night.